The role of the SI joint in the diagnosis of back pain is this cesspool of weirdness. Because most of the time people will say, my SI is this, yet there's not even been any diagnosis. That's a self-diagnosis. They feel something that maybe is below their belt, so they say it's their SI. Well, look, by definition, the SI could be involved. It may not be involved. It may be involved with something else. All of these things are possible. So to suggest that the SI doesn't move, which is, sometimes you're going to see that in an orthopedic world. I think in the osteopathic world, you'll find a lot more gravity of where the SI fits in, how to evaluate for it, how the anatomy can be impactful, et cetera, et cetera. So if I can dislocate the SI here, or maybe even before I do that, keep in mind that the SI joint that I would champion, or might be different worlds on how they communicate things, would be S1, S2, and S3. Okay, there's 3 levels of the actual joint system of the SI. And you see I kind of create this little curve. So now if I can dislocate, the SI joint would kind of look like it would have a length that comes forwards, it would have a length that goes straight, and then a length that goes forward again. So if I were to draw it, it would have a length that goes this way, it would have a length that goes this way, and a length that goes that way. So at the top at S1, it's a shorter component. That's the lesser arm. And the lesser arm has a base and an apex, okay? S2, and how you can find it, S2 is typically where the PSIS would be. That's the isthmus. And then the length that is a little bit longer is the greater arm. And again, there's a base and an apex. So using that language, which may not be the same language you'll see in every osteopathic teaching module, find out where there's a limitation, where is there not movement, maybe where is there too much movement. Because you would have to suggest that anything involving the hip attaches to the pelvis, which then attaches to the SI. We got to look. And you will probably find, whether it's your manual therapy for pumping or the ELDOA that you would follow it up with, you'll find that a lot of internal rotation problems are all from the lesser arm. And if you just try it really quick and it changes, money. Stop worrying about the other stuff. Don't stretch the local tissues if that's what works. That's the value of whether you have needles or hands really and can knock something off the board really, really quickly. Greater arm, S3, would be more related to external rotation. But now, wherever you have any of these issues, from the lumbar south, we got to look at the SI. From the hip north, we got to look at the SI. Anything down here where the hip is going to be involved, you got to look. And I don't know that you need to look at all that stuff on day one, but to suggest that some people, that the SI doesn't move, it only moves a little bit, whatever. And even if you can't prove with your hands and your eyes that you're creating something that is sensory motor at the SI joint, if the person does something that you want it to do, that's the whole concept of, does it really matter why it works, or does it matter more that it just works? It all just depends. In this case, to not specifically intervene on these movements, and there's lots of language and nomenclature that would describe different things, muscle energy technique, a lot of these things that live in more of an osteopathic literature would really put the SI into more component. And of course, you're going to find that there's some people that always want to start with the SI. Some people want to start with the hips. I don't know how you can talk about the hips without the SI. You want to start with the feet. You want to start with the neck. Whatever it is, if you get there and you're satisfied and you can then train, you're done. You're out of it. But in these cases, trying to understand the greater arm, the isthmus, the lesser arm, so there's pumping for all of them, and the isthmus has 2, so there's 6 pumping manual therapy techniques. You have an ELDOA, 1, 2, 3, 4, 5. There's only 1 ELDOA for the isthmus. And then some of the unique diagnosis that you'll find in ELDOA land, there's other types of positions that you would use to create the result. Muscle energy technique, different positions, understanding different positions, and it's all based on palpation, which for me has never been very, very successful. I always say if somebody's got a lot of distance between the skin and some of these anatomical landmarks, I'm like, how are you going to know this? It really frustrated me. And that would be something that even I think we learned that in PT school. I don't know that it's all the same because there seems to be like some different variations and different schools of thought that would all fit under the same model. But to suggest that the SI joint is something other than a series of 3 joints and lots of different connections amongst those joints. This is what it is. We have to look at it, and we have to have a plan if that is where we think the limiting factor is, just like we would everywhere else in the body.